Welcome to the Paediatric FH webinar. Thank you for joining. It's greatly appreciated. I'm Syra Nazir and I'm the Paediatric FH specialist nurse based at St Mary's Hospital in Manchester. I wanted to take the opportunity to discuss paediatric FH and to really elaborate further following on from the newsletter which was disseminated in March 2025 regarding paediatric FH, as well as to provide an opportunity to discuss any cases or questions which you may have. So as part of today's presentation, I'll be discussing what is FH, the signs and symptoms of FH, the referral criteria in terms of when and where to refer children who we suspect may have FH, the management of FH and the role of primary care with managing FH. So starting with what is FH. FH, it stands for Familial Hypercholesterolemia, and they're Greek words which stand for high cholesterol runs in the family. FH, it's an autosomal dominant genetic condition, which means there's a 50% chance of inheriting the condition, and only one faulty gene is needed to be affected. It's one of the most common genetic conditions, affecting 1 in every 250 people throughout the UK. It's actually the fourth leading risk factor contributing to deaths in the UK. So there's been a drive to create FH services to identify, diagnose, manage and improve patient outcomes since 2008 for that reason. It's estimated that there's around 270,000 people in the UK have FH, but many don't know that they do. And it's caused by genetic mutations in any of the following genes: the LDLR gene, the ApoB gene, the PCSK9 gene, and the ApoE gene. And I'll be explaining those genes in more detail just in the next slide. So by having faults in any of those genes results in raised LDL cholesterol levels due to the liver being less able to remove excess LDL cholesterol, and having FH means individuals are at greater risk of cardiovascular disease, such as stroke or death at an early age if it's not treated. It also forms atherosclerosis in the coronary arteries. And having high blood pressure or smoking further increases the risk of atherosclerosis. There's 3 types of FH. There's heterozygous FH, homozygous FH, and polygenic FH. Heterozygous FH means an individual only needs to inherit 1 copy of the faulty gene, whereas homozygous FH means an individual's inherited 2 copies of the faulty gene. So in that situation, they've inherited 1 copy from mum and 1 copy from dad. But heterozygous, as I said, you only need to inherit 1 copy to be affected with that type of FH, and that means that faulty gene has been inherited from mum or dad, whichever parent is the affected parent. And then finally, polygenic FH, that means we don't know which mutations could be causing an individual to have high cholesterol levels. However, if an individual does have high cholesterol levels and there's a family history, then it could be caused by multiple unknown mutations, and we would then diagnose the child as having polygenic FH. So this is the cholesterol metabolism pathway, and I will try my best to explain how these pathways work. So this is how the pathways normally work. So starting with the left-hand side, focusing on the LDL receptor, and then I'll move over to the ApoB, the PCSK9, and I will explain how the ApoE pathway works as well, even though there isn't a diagram for that pathway. So normally, focusing on the LDL receptor, that receptor attaches to LDL cholesterol and transports LDL cholesterol into the cell. LDL cholesterol is then broken down and either used by the cell, stored or removed from the body. Moving on to the ApoB gene. ApoB allows LDL cholesterol to attach to specific receptors on the surface of cells, particularly in the liver. Once attached, the receptors transport LDL cholesterol into the cell, which is then broken down and either used by the cell, stored, or removed by the body. Moving on to the PCSK9 pathway. So the liver makes a protein called PCSK9. PCSK9 regulates how many LDL receptors an individual has. Having too much PCSK9 causes more cholesterol, as high levels of PCSK9 breaks down the LDL receptors. And then finally, the ApoE pathway. So ApoE is involved in making a protein that helps carry cholesterol and other types of fat in the bloodstream. So that's how those pathways work normally. However, if there are mutations, so faults in any of those genes, any of those pathways, that results in the above processes and pathways not functioning correctly, which then results in high levels of LDL cholesterol to be stored in the body because the body is unable to remove the excess LDL cholesterol that isn't required. Moving on to FH signs and symptoms. So signs and symptoms can present either through the family history and or through clinical findings for the child. So when we're assessing our patients, and if any of the following information becomes applicable, these are the situations when we should start to consider whether we're suspecting FH. So if any family member has hypercholesterolemia and or already has a genetically confirmed diagnosis of FH, and or if any family member, including the patient, has had early cardiovascular disease at a young age, so for example, a heart attack, stroke, hypertension, or cardiovascular disease related death at a young age, these are strong identifiers to suspect whether they themselves have FH and their immediate family members as well. Alternatively, if a child was having a routine blood test, for instance, and the child presented with hypercholesterolemia, so specifically raised LDL cholesterol levels, that with the family history are strong contenders to suspect FH in these situations. Equally, if the child has hypertension or any of the following clinical signs and symptoms, then again, these are all strong clinical signs and symptoms. The attendant xanthomata, that's swelling to the knuckles or the knees or the joint areas, and that's because a buildup of cholesterol builds up in those body areas. Xanthelasmas, they're pale yellow lumps which appear on the eyelids, on the tops and the bottoms of the eyelids. A corneal arcus is a pale white ring on the iris of the eye. And then Achilles tendon pain can also be a clinical sign and symptom of FH. And that's just because the cholesterol builds up in all of these body areas. These are the raised LDL cholesterol levels associated with FH. These levels do differ to target ranges for the general population who don't have FH, but these are the target ranges which we use to help manage LDL cholesterol levels for children who do have FH. So for children who are under the age of 8 years old, an abnormal LDL cholesterol level is anything over 4 millimoles per litre. For children aged 8 to 14 years old, abnormal LDL cholesterol levels are anything over 3.5 millimoles per litre. And then for children who are aged 14 to 18 years old, abnormal LDL cholesterol levels are anything over 2.5 millimoles per litre. So if the family history, which I mentioned in the previous slide, and if the child has the clinical findings, which I also shared in the previous slide. So when we're in this situation, please do refer the child and their siblings to me if they are up to and including 16 years old. So please refer them to the Paediatric Familial Hypercholesterolemia Specialist Nurse at St Mary's Hospital in Manchester for investigation, diagnosis and management of FH. And then for children who are 16 and above and the suspected parent who the child may have inherited FH from, please refer those individuals to the local adult lipid team for investigation, diagnosis and management. And just to reiterate, in order for them to meet the eligibility criteria, there must be a family history of either hypercholesterolemia and or early cardiovascular disease in order for the referral to be accepted by the FH service. So in terms of completing the referral, we kindly ask for the following information to be included just to help put everything into context and just to help us triage the referrals appropriately. So within the referral, we kindly ask for a detailed family history, focusing on who has or had, if they've passed away, has hypercholesterolemia or a genetically confirmed diagnosis of FH. Please send a copy of the affected individual's FH genetic test report if that is available within your system and the individual consents for you to send that. Or if early cardiovascular disease is applicable, again, who has or had early cardiovascular disease or cardiovascular disease related death at a young age. How old were they when they were diagnosed with hypercholesterolemia? How old were they when they had early cardiovascular disease or CVD related death? Has anyone had FH genetic testing so far? Is anyone under the care of a local adult lipid team? If not, who manages their hypercholesterolemia at this point in time? Or have any family members now been referred to a local adult lipid team, and which team have they been referred to in case the paediatric team needs to liaise with the relevant adult team and vice versa? If any of the following results are available, then we kindly ask for those to also please be included within the referral. So focusing on blood test results, specifically lipid levels, and again, specifically LDL cholesterol levels, as that's the most important. Their liver function levels, thyroid function, creatine kinase, FH genetic testing, blood pressure, height, weight, body mass index. Not to worry if those tests have not been completed or can't be completed. It's only if these tests have happened to have been completed at any point in their lives. All these results will be extremely helpful. And I thought I would just include the referral address to send all referrals to for children. So I can accept referrals by post as a letter, as long as the referral is in the child or children's names, and each child would require a separate referral letter, please. Alternatively, I can also accept referrals as an email attachment. Again, each attachment needs to be a referral on letter-headed paper, please, and each referral would need to be for each child individually, please, which would include the child's name, the date of birth, their NHS number, and their address, as well as all the other information that I previously mentioned in the previous slides. And then for children who are over the age of 16, and or their parents, they would need to be referred to the local adult lipid team, because there are multiple adult lipid teams throughout the Northwest. I've just included a web link to help search and find the closest adult lipid clinic for the relevant families. So for children and families who reside in Liverpool, Merseyside and Cheshire, they may prefer to be referred to the paediatric FH service at Alderhay Children's Hospital. and the clinician for that service is Dr. Joe Blair, and I've included their postal address and their telephone number if you have any relevant families who you would like to refer to their team instead. If Alderhay is closer than Manchester, then that's absolutely understandable. So that they're their contact details if required. And for children who are over 16 and for parents who are to be referred to the adult lipid team, again for those areas, if the Liverpool team is closer for them, then the Liverpool Heart and Chest Hospital is the closest adult lipid team for them. However, all of the children and families that reside in the Northwest, other than those areas, they can still be referred to me. And equally, if children and families do live in Liverpool, Merseyside and Cheshire, however, St Mary's Hospital in Manchester is closer for them, then they can still be referred to me at St Mary's Hospital instead. Moving on to the management of FH. FH genetic testing is completed for children who have hypercholesterolemia, so specifically raised LDL cholesterol levels, where there's also a family history of hypercholesterolemia or early cardiovascular disease. So a child will then meet the criteria for FH genetic testing in those situations. But equally, for children where their parents or already has a known genetic mutation identified, then the child or children of those parents are automatically eligible for FH genetic testing in those situations, and that's what we refer to as the cascade screening. So we check their lipid levels, and again, LDL cholesterol level is the most important. We check their liver function, thyroid function, creatine kinase, criteria for FH genetic testing. We also measure their blood pressure, their height, and their weight, and their BMI. If they're positive and they have hypercholesterolemia, we then start them on a statin, and we can start that from the age of 8 years old. That's the earliest we try to wait until starting a child on a statin, even if they have hypercholesterolemia at an earlier age. So if they're 4 years old, for instance, and they have hypercholesterolemia, we have to weigh out benefit over risk, and we aim to wait until they're 8 years old before starting them on a statin, unless they have homozygous FH, because that then does change the situation. We also promote lifestyle changes, so we advise them to have a healthy, balanced diet, complete regular exercise, to avoid smoking and vaping, and to reduce their alcohol intake when they're older. It's a dietitian, a specialist dietitian, who provides the dietary advice. But then at follow-up appointments, it'll be myself who would reassess their diets and activity levels at all future appointments. And then finally, the role of primary care with managing FH. So the following criteria would apply to professionals within primary care, please. And as we've mentioned, the starting point would be to refer children and adults to the relevant teams for investigation, diagnosis and management. And for positive patients, the next step would be for the FH services to ask GPs to kindly prescribe the relevant FH medications, which is usually a statin to begin with, but other medications may also be required. We also kindly ask for follow-up blood tests to be completed, please. Reason being is that even though the FH team, like myself, is based at St Mary's Hospital in Manchester, the family may well reside in Lancaster or Lancashire, and it's easier for families to have blood tests close to home, prior to their appointment, and for the results to be sent to myself, for instance, which I will review before their appointment in order to complete a full appointment and put a plan in place at the time of the appointment. Whereas if blood tests were to be completed during the clinic appointment, then it means that a plan can't be decided at that point in time, and then there'll be a delay to wait for the blood test results and then waiting to follow up with the parents to then discuss and decide the appropriate plan, which can become counterproductive. So we kindly ask if follow-up blood tests can be completed in primary care. We'll be extremely grateful, and it just helps for a productive and thorough clinic appointment to then be completed. And we also kindly ask for positive patients for their diagnoses to be coded within primary care as well, please. So once again, here are my contact details. So I've also included my contact numbers as well on this occasion. And I thought I should also share some useful resources if anybody would like to receive further information about FH. So Heart UK, which is a charity, their website is extremely useful with explaining what FH is, and lots of advice resources as well are on their website. The Simon Broom diagnostic criteria and the Dutch criteria for FH are really useful tools to help assess whether we should be suspecting FH for certain individuals. We also have NICE guidelines, we have current management guidelines, we also have education programs and modules as well. And then on the next slide, these are all the web links for all those resources that I've just mentioned, if anybody would like to research any further information. And finally, I'm more than happy to take any questions, or if anybody has any cases or queries that they would like to discuss, I am more than happy to discuss them now, as long as we're maintaining confidentiality. Thank you all so much for joining. I hope you found this useful.